Well, thank you very much for that kind introduction. Okay, so I was given this mandate to answer this question: continuous glucose monitoring in diabetes management, do they really help? So this continuous glucose monitoring here means flash monitoring or real-time monitoring. I use them all. So I only have 20 minutes to answer this, so I'm going to move on now. Now, I've got no financial disclosures, nothing for the purposes of this talk. Now, given that this is in the symposium known as Diabetes in Asia, I thought it apt to bring out this IDF atlas around the world. Now, if you take a look, this is 1 in 10 adults with diabetes, 537 million worldwide. This is a very, very common condition. I'm going to dredge out Southeast Asia here, and you see 90 million and going up to 152 million, which is 68%. There is something a little bit odd here. You are not Southeast Asia. I come from Singapore. Geographically, you are South Asia. I'm not sure why, and I've asked Peter Schwartz, and nobody knows why. So it's considered Southeast Asia in this region. If you look at this, this is geographically Asia. This is South Asia. I'm Southeast Asia. So interestingly, the next speaker is China, and from China. So we are considered Western Pacific. We are very, very different. Yeah, East Asia, China, Southeast Asia, where is Singapore, is there as well, and Australia. So go figure. And just wondering, if you're wondering where I'm from, I can't find myself. I have to squint. That's exactly where I'm from. That's Singapore. It's a little red dot. You have to imagine. So the question then is, continuous glucose monitoring in diabetes, do they really help? Now, to know this and to see how far we have come, let's go from the very beginning. Did you know this, that in the 1600s, the doctors have to diagnose diabetes by tasting a urine, talking about giving everything for medicine. Now, interestingly, I got this out, and in the 5th century BC, given I'm having a talk in a minute about now, the apparently famous Indian surgeon, you might know him, Shushruta, in his work Samhita, I'm sorry if I pronounced it wrongly, identified diabetes by using the term madhumeha, which is honey-like urine, and pointed out not only the sweet taste of the urine, but also its sticky feeling to the touch and its ability to attract the ants. They put in exclamation mark. I copied and pasted. It was really in the article. Happily, since then, in the early parts of in 1900s, we started having Benedict's reagent, and with different coloring showing the different concentrations of sugars. And then we have this, some of you know this, we still have this in a lot of outpatient settings where it's semi-quantitative in terms of glucose. And then in the 1980s, that's where glucose monitoring came about. And then 1990s onwards, really actually in the last 1 decade. And this is the timelines of CGMS from the 1999 until now. So again, really in the last few years, in the beginning, it was clunky. It was also only 3 days that you can use it, quite a lot of issues, but then now we have more and more, and it's more rapidly developing. So the question then is this: so does it really help? Well, with the talk will focus on 3 aspects then. Number 1, logically. Number 2, data. And I'm going to go and give you clinical scenarios. So logically, remember this chart. Well, I mean, for me, I would prefer not to taste the urine of my patients to determine whether the glucose is high or not, but that's me. If you have a different thinking from me, of course, you're welcome to your opinion. And obviously, the glucose in the urine is quantitative, so it would be great for me to have something which is going to be continuous. And I remember the times, I remember now, I've got patients coming up to you, remember they prick, and then you can tell whether the person really does it or he's faking the results by the blood stains on the finger prick report. So, well, it's ouch. And sometimes for my diabetic patients who are gestational diabetes, sometimes 9 times a day they have to do it. That's a pretty poor thing. So, and no matter how many you do, it's like a blind person touching the elephant. You are not seeing the complete picture. This is opposed to CGMS, continuous glucose monitoring. And this is CGMS 24/7, 365 days if you decide to put it on. So this has revolutionized diabetes through the years. So that logically, to me, certainly I want CGMS. Now, what about data? Do we have data? Yes, we have lots and lots of data, but I have stretched out the two reports in the 2025, and they are from real world evidence from this. So one of this is this, which is a meta-analysis of 8 observational studies, assess the change in HbA1c at 3 to 6 months following initiation of flash glucose monitoring in type 2 diabetes, which are treated with insulin. So these are 8,800 patients, mean age 62, mean HbA1c is 9%, and they found that the initiation of CGM led to a mean decrease in HbA1c of 0.89%. That is equivalent to one medication. So there's a second data that came out. This was, to me, even more evidence in terms of this, because not just HbA1c, but clinical outcomes. So initiation linked to improved glycemic control that we saw just now, and also fewer clinical events in both type 1 and type 2 diabetes in the Veterans Health Administration. So you see the whopping numbers there, because this huge database from the VA hospitals. So this is type 1 diabetes, 4,900 against 3,000 over type 2 diabetes, 15,000 who initiated it against 28,000 who did not. And this is in 1 year's time. What was the 12-month change in HbA1c? Okay, so this is 0.26%. Minus 0.26, and then for the type 2 diabetes, minus 0.35. What about the clinical events over 12 months? Looking at hypoglycemic admissions, we have 0.69 for type 1 diabetes, 0.92 for type 2. Hyperglycemic admissions, 0.83, 0.87. And all hospitalizations, 0.75 and 0.89 in terms of initiation of CGMS. So you have, logically, you have data, and then let's look at clinical scenarios to see some tips for practice. So this is case 1. She's all these are real patients. 48-year-old female, diabetes diagnosed since 2014, first seen by me on 23rd of November. She's 7.5% on glycoside, 7.5 milligrams in the morning, 5 milligrams at night, metformin, 500 milligrams 2 times a day. The 1 hour postprandial is 11.7 and fasting of 8.0. Family history strong on the mother's side. What do you think? Run of the mill, right? I can give her another medication, it's all good, just lose weight, eat healthily. When she was first diagnosed, she was 42 kilograms, 1.57 meters. Her current weight when I saw her was 36.3 kilograms, BMI of 14.7. This lady is starving herself just to get on 2 medications, 7.5%. And yet, despite that, the fasting is 8.0. She is not run-of-the-mill. Something else is going on. So her HbA1c then was 6.9% on starvation diet. We have 27% is high. I'm not here to teach you how to use it. It's just the mandate. Is it going to be helpful? So I'm going to show you why. So this was 24/7. And this is how it is. So variability, quite a lot of variability with the food. She eats a little bit. Remember, she's BMI of 14.7, 36 kilograms. She eats a little bit, boom, it still goes up high. How much can she eat? 3 months later, this is her variability. What did I do? I managed to convince her to start insulin. 2014 until 2022, refused. Until now, she finally did. HbA1c was 6.3%. Novo Rapid, 3 times per day when working for home. Otherwise, it's a minimum about 2 times per day. Tojo, 9 units, very sensitive to insulin. Yeah? She was managed to put on 36.3. Now, weight is a complex issue, but so she managed to put on 36.3 to 37.7 kilograms. So this was what she was before, and this was 3 months later, a difference in 6.9% to 6.3%. The highs much less now, and the variability is also less. And this is how she was after 3 months, and on almost basal, almost basal bolus, or rather bolus plus, a basal plus. So the learning points for this is a patient who starved herself, was very severely underweight without the CGMS, without looking at it. I'm giving it to her. I'm letting her look at it. She finally understands what it is. Why is it, no matter how much she starves, the glucose is still going to be high. There's something else inherently going on. So this is a picture paints 1,000 words. And that is helpful to convince my patients to start insulin. It doesn't have to be her. Hers was just an extreme case, which was interesting that I brought up. So able to help. So with this, you are able to help the patient to start insulin and also to escalate management, because there's a lot of inertia with regards to escalating management, whether it's adding on another oral hypoglycemics or whether it's adding on insulin. Now, this is the second case, 57-year-old female. She was referred by an oncologist, breast cancer, neoadjuvant chemo and surgery. Baseline pre-chemo bloods came back, a random glucose, which is sky high, HbA1c 11.5%. She never knew she had diabetes. She didn't have any inkling. Family history, diabetes, but she's a known case of hypertension, BMI 24.8, weight is 63.4. And I first saw her on 16th of February 2023. This is not uncommon, yeah, whether your cardiothoracic surgeon comes to you, they think you can work miracles. Oncologist comes to you and say, I want a chemo on 21st of February morning, and I'm going to give her IV steroids, and she's just going to dump it in your lap. Okay, so what did I do? Slept on CGMS, got drugs. So let me show you then what happened to this gentleman. Let's say, oops, okay, this is not working. Any IT guy? No IT guy. It worked just now in the preview, but it's not working now. How do I play it? Yes. Okay, never mind. Let's not waste time. We'll go on. Because it did work in preview, during the preview. Okay. Oh, here we go. Now it works. Okay. Okay. So, now I can't stop it. The barriers to diabetes management and the use of CGMS. Okay. Now I can get rid of it. Oh, here we go. Here we go. I don't know how. Okay, so we started here. Okay, so it's beautiful. The picture paints 1,000 words here. So started here. I put on the oral medications. I started on insulin, basal insulin. Yes. Now within 1 day, that's your levels. Then remember, 21st in the morning they wanted to start chemo. Yeah. Okay. 19th February, 20th, 21st. Yeah? Can start chemo, no problems. Open heart surgery, also possible. But then the oncologist said, I'm sorry, we didn't have dates, so we are not starting chemo now. Okay, never mind. Moving on. So guess when chemo was started? You can tell. This blue. Chemo was started here because chemo came with DAXA. So this shows you what happens after dexamethasone. Okay? And you see after the dexamethasone, it's at a higher level, the fasting insulin. So steroids is bad for diabetes. And then afterwards, it takes some time, and then it goes down again to baseline, what it was supposed to be without the DAXA. Okay, so that's, now I want to show you. Okay, so then, okay, so if this was initially, it's 6.5 because that's the other thing good about CGMS. HbA1c 3 to 4 months, yes, because of the red blood cell lifespan. But on the CGMS, it's 2 weeks. Within 2 weeks, I know that it's working, it's 6.5%. This is 5.7% after. And this is what it was before that, and then you have it now. The learning point for this is helps to alleviate stress. Why? This is a patient who was newly diagnosed with breast cancer, operated, And then now she's told that before she's giving chemotherapy, she has diabetes, which she never knew that she had. So this is a very stressful situation. She doesn't know what she eats. She doesn't know what to do. So this helps to educate where the carb sources are. Just with that, the dietitian gives you theory. They can tell you that carbohydrates are in this. But for her, for anyone who's on the CGMS, that is targeted to what they are eating. They can immediately see where the carbohydrates are coming from. And therefore, I use them whether it's newly diagnosed after oncology, after breast cancer, or a type 2, a type 1, anything. Just because it's good to educate on where the carb sources are. It also captures continuous data over different situations after DASG, and also after exercising, educates on activity and glucose. So even if I had to use it, even if I use it once, I'll be very happy with this. And my patients feel very happy with that as well, because they get to see the different things that they do and how it impacts on glucose. Now this one, I hope this. Okay, you just take a look at the glucose, okay? Just take a quick look. Okay. Oops. Question, what have you noticed? Yeah? If I told you then, this is a Singapore king of fruits. 1 kilogram, it's 25 US dollars. It's very pungent. It's banned from hotels. It's called durians. This is Musang King, Mao Shanwang. It's a fruit, but 3 seeds of this is 27 grams. There was this patient ate 30 seeds. That's 270 grams of carbohydrates. 15 grams is 1 slice of bread. That's a lot of slices of bread. 8.3. What does it say? That was me. You need to know, this is good to me, just for the fun of it, to know what normality is. That glucose is actually very controlled and very tightly controlled in patients with no diabetes. To be careful in overdiagnosing about hypoglycemia. Technology is everywhere. I love this because not to show my glucose levels, because I have patients coming up to me because they have slept on CGMS and they say they have hypoglycemia, but I show them mine and show them that actually there's overdiagnosing. There also hypoglycemia is an artificial construct. You know, it was not 3.6. Yeah, the Whippers try it. It's 2.8 millimoles, it's neurosymptomatic, and then relief with glucose. So it's slightly different. Yeah. So the second thing is that we use it for patients as well, because the patients who remember about the proactive escalation, and there's a lot of inertia increasing, whether to insulin or otherwise, to show them what normality means. So they're able to compare. If it's always on the high levels, they have come to me before and told me that, you know, my body works on a higher level than everybody else. I don't feel anything, so that's good. It's no need to bring down the glucose to a normal level. So this helps me with all these groups of patients as well. So now, this final case then, she's 28 years old, Miss AH. She's diagnosed, 21 years old, started on insulin. Referred by eye doctor who saw her for bilateral proliferative diabetic retinopathy, vitreous hemorrhage, needed intravitreal anti-VEGF. The medication she was on was basal bolus, glargine 30 units at 10 p.m., glucosin 20 units 3 times a day, empagliflozin dual 12.5 850, amlodipine, kanisatan, so lipids and diabetes and hypertension. If I showed this to you, if I showed this to you, it tells you a different picture. It tells me type 1 or type 2. This is type 2. This is type 1. There's no insulin reserves. So from that, it helps physicians to see, it helps me to see whether this is type 1 or type 2. And if this is type 1, this is type 2, because why is it that type 1 is all over the place? Because there's no insulin reserve. You don't have enough, it goes up. You have too much, it goes down. You have hypoglycemia, whereas type 2 looks typically like this. And this is important to me, because when she comes to me on basal bolus at 28 years old, and is type 2, why is she on basal bolus? Her HbA1c was 5.6%, her C-peptides was 3.54, beautiful. And her weight was 89.3, and her BMI was 34.9, class 2. The weight keeps increasing, it never could decrease. So what do you want to do? So what happened was, I saw her on the 10th of January. I told her, you are taking off all your rapid-acting insulin. She looked at me in shock, and she was very fearful. I said, stop it, you take 30 grams. She was a very, very bright lady. She knew where her grams, she could do carbohydrate insulin counting. But I don't know why it's 20 units 3 times a day. So I say, take off all Novorapid and give me 30 grams per day. This is 2 dinner, 1 dinner, 1 breakfast. See how flat it is. So within 12 hours, I have decreased the insulin dosage by 60 units per day. I saw her via Zoom on the 24th of January 2025, which is 2 weeks later. Her line continued being flat, 0 glutathione, 0.6 milligrams GLP-1 started. Glargine was dropped from 30 to 22 units. Weight loss of 3 kilograms in a lady who had to chase 20 units per day and ate 20 units per day and couldn't reduce weight. I updated just for this talk. I asked her how she was doing. She was not in Singapore. She's actually in Indonesia. And that's one of the great things of this, because you cannot hide from the doctors. We tweeted out, and then we had a Zoom, and I could share screen with her for CGMS. Updated on 13th of February. That's how it looks. That's flat. And that's still how it looks. Lentus was 12 units, 84 kilograms, lost further weight. And what did I tell her? I say, you go down to 8 units, and then just before I see you, which is in 2 weeks from now, give me 0 insulin, and let's see how it goes. And if you're wondering why is it I do that, and why there's CGMS, because it's reassurance. She's been all her life on insulin, and she didn't dare to remove it. So the learning points from this, CGM profile is very helpful to me to aid in differentiation of the types of diabetes, a close monitoring to see the success of the insulin removal and to allay the anxiety of this patient. And it aids my patient to see where the carbs are coming from, and to decrease carbs, you also aid in weight loss. And it's a confidence booster to see that there's no hyperglycemia and that she could continue on this regime. So in conclusions, if you ask me then, the mandate I had was to answer these questions. Continuous glucose monitoring, diabetes management, do they really help? Logically, yes. Data-wise, yes. HbA1c as well as clinical outcomes data. Clinical scenarios, definitely yes to me. I am so pampered. I can't do without this anymore. And in fact, some of my patients tell me that they want to continue. I say, why are you continuing? It's flat. It might be for reassurance. It might be because they are globe-trotting. They are so obsessive. They want to know where the carbs are coming from. I say, whatever rocks your boat, that's fine. For me, I might not need your CGMS. If you want to use it, if you feel that it helps you, go ahead and use it. But of course, we live in the real world. Cost effectiveness, one thing. I would definitely use at least once for a type 2 diabetes, but I'm aware that it might be expensive depending on which flash monitoring device. But I also know that advanced technology is coming, and it's getting more cheaper and cheaper. So, I'm going to answer that question. Do they really help? Yes. That's not about cost first, but do they really help? Yes. Invaluable in the practice. Thank you very much.
Thank you.